if we are going to do that, what problems are we going to encounter? And this third segment is about, how are we going to overcome those problems? Now, I'm trying to the reason for disability. The numbers are staggering. This is a public health issue. And I think I have to use the computer. And that makes sense. That it used to be number 1, number 2, number 3 in the United States. Then it became number 4 globally in 2015. And now global is number 1 reason for disability. And the simple reason for that is that society is aging, not only in our country, but in most of the countries around the world. As a matter of fact, these are the numbers, these are statistics. By the time you are 50 years old, there's only 32% chance you don't have spine problem. By the time you're 70 years old, there's only 1 to 2% chance you don't have spine problem. Not all of them need surgery, thanks God, but and not all of them need fusion, but percentually that number is increasing. How much that number is increasing? Staggering. This is not a rare disease. This is truly a public health, a huge financial economic issue. So there is a problem, and this problem needs new way to look at it. Now, for people who know, going from open to MIS is not about the skin incision, about what happens under the skin that makes a surgery MIS. And more or less, we don't tell our patient in open surgery, we separate all those muscles and we don't reattach any of that. Our orthopedic colleagues here know how it works, that if you do a shoulder surgery and you don't reattach the tendon, you're rendering that joint physiologically ineffective. But as well, I think one of the problems with open traditional surgery is that we are interrupting the feed loop back mechanism of muscle regulation, and that has a huge impact on recovery and time to recover. The third aspect of the MIS versus open, or I would say muscle sparing versus non-muscle sparing, is the vascularization of the bone. That's another thing that we don't tell most of our patients, that patient does not have an artery of L4 or L5. The vascularization of most of our bone is through surrounding muscle. In traditional TLIF, PLIF, you're separating vast majority of the muscle attached to the vertebral body, which are posterior. This study is done in 1930s, that by practically 75% of the vascularization of the vertebral body is through posterior element. When you do a traditional PLIF or TLIF, go all the way to the lateral gutter, practically you're reducing the vascularization of the bone to 25% of the original value. This is a patient of mine. On the left, you see a 2-level TLIF in 2012. 2 years later, in 2014, I did a 1-level transcambing OLLIF. In 2015, patient had a car accident. I had to take the patient back, and we all understand where we do TLIF, when you go 6 months later back, there's no muscle there. Everything is a solid scar and very less vascularized. But in muscle sparing technique, as expected, there is virtually no scar. And all those muscles that they don't turn into scar can help the patient to recover. This is as well a patient of mine. 1-level TLIF, even 2 levels above it, as you may see in the upper left, the multifidus muscle has turned into a scar. All of this not only have overall impact on the outcome, but as well has an impact on how fast can you let the patient go home, because patient has to recover from that. Another very important factor doing a surgery as an outpatient is the time under anesthesia. And if anybody has a doubt about that time under anesthesia is important, talk to your anesthesiologist. Generally, in most of surgery centers, and your anesthesiologist won't accept any cases that the total anesthesia time is more than 3 hours. And this is not quantified. This is based on almost 388,000 patient meta-analysis that shows every additional half an hour under anesthesia adds 17% to the combined risk of the surgery. And practically, the math of it comes out to surgeries under 2 hours are half as risky than surgeries under above 2 hours. And that has been significantly quantified. Now, I'm going today obviously talk about 2 of the methods that I use to reduce overcome these problems. One of them is oblique lateral posterior lumbar interbody fusion. That's very distinct from OLLIF ATP anterior to psoas. And another, and I have been doing that for the last 12 years. And then another procedure, MIS-TLF, partly prone lateral with the same instrumentation. Now, the result I'm going to give you is based on 1,550 patients and over 3,000 levels. So to have 12 years of data gathered and collected, and we have published multiple papers about this. And this surgery, with some modification, can be done in a vast variety of levels, including 5S1. I think that's a crucial thing. And we have published numerous papers about different techniques to overcome certain technical difficulty of this. But based on 1,550 cases, about 39% of our fusion, this is no discectomy, this is not a decompression, these are all fusions. 39% are under 1 hour, 95% are under 2 hours, and 99.4% of the surgery are under 3 hours. And I'm talking not about 1 and 2 level fusion on a BMI of 22. I'm talking about 3 and 4 level fusion on 80-year-old people with BMI above 50 included in that data set. Now, this is one of the papers we published, and as expected, you see that the blue line is a regular TLIF with higher BMI. The time under anesthesia correlate directly with the immediate perioperative outcome, and as expected, higher BMI relates to more problem. That the red line is a star TLIF, MIS-TLIF surgeon, somebody who has done thousands of MIS-TLIF, and even in his hand, it's very efficient, but then at the BMI of 37, it almost flipped. We know about that. Higher level of complexity are less suitable for MIS. Now, the transcameral OLLIF is the green line right down there. And in the second study, we could show that even higher complexity, the BMI is not a big factor in performance of the surgery, because once the tube is in place, it doesn't matter if you go through 2-inch or 4-inch of adipose tissue. And I think this is one of the reasons why we can shift this patient to the surgery center. 96% of these patients are ambulating within the first 24 hours, and so they can go home within the first 24 hours. As a matter of fact, these are comparable numbers about how these surgeries are done. Yesterday, just before I came over, we did 4 fusions in our surgery center, and everybody went home at 4 o'clock. So by following certain algorithmic ways, and I'm going to talk about it a little, you can literally replicate the results. And too bad Dr. Gasco is not here. He was planning to be here until he got sick, but he has, in the last year and a half or 2 years, a lot of experience with that, and I was really looking forward to listen about his experience as a proof that this is not a surgeon-specific, but the technique-specific results. This is practically the average discharge of the patient to home for the similar fusion. And in one of the hospitals that we are the only people providing this care, most average hospital stay, including elderly, multi-level, is 1.6 days. Now, who can we do this surgery for? I mean, the papers are written. I'm sure if you're interested, please contact me. We can talk more about it. And we have even observation in our own permanent lab. The indication for this surgery is totally based on your experience. Obviously, I didn't start with a case like this. I started with 1 level, no significant deformity, no grade 2 listhesis. But once you get good with the instrumentation, with the initial algorithmic procedure, you can just replicate it, and then you can do this. Now, this is done through multiple small incision, and practically the result of that we do that kind of surgery day in, day out, over 1,550 cases in performance like this. And everybody who goes through the learning curve can perform this at the same level. So You truly need to be just a surgeon to be able algorithmically follow this, and that is the word algorithms come from, following certain level that gives you the same results. The results are patient that otherwise would not be really suitable for open traditional surgery. Like this patient was legitimately rejected by 3 other surgeons for traditional surgery, bad, heart, elderly osteoporosis, lots of different factors that would prevent that practically she was just told, the only option she has is living with that. But now by reducing the trauma associated with surgery, all of a sudden you can provide them with a choice. Now, I'm going to talk just a little about the technique. I'm sure most of you are familiar with the cambium triangle. I used 2 C-arm, and it took me just 250 cases to learn what is the optimum positioning of those 2 C-arms. So this knowledge is really gained the hard way. In the AP and lateral, and that's what it is, 2 C-arm, every time I shoot an X-ray, I re-register the patient based on anatomical knowledge. We identified the midline of the disc in the AP and lateral, and then with the neuromonitoring probe, we approach the cambium triangle with 3 milliamp stimulation. Then we enter the disc. Before that, we stimulate at 4 milliamp. Then a K-wire goes in, a dilator goes in, and a tube, 8 millimeter tube inside, 10 millimeter outside goes in. And then the magic is about the instrumentation. You will see some of that in the other room. And it is only about this truly advanced instrumentation that we can go through an 8 millimeter tube, perform discectomy, and prepare the end plate. And there, I'm always asked, can you do discectomy? Can you prepare the end plate? With the right instrumentation, absolutely. Another thing is, but some experience, you can choose where you put the cage. You can put the cage right or left, front or back, and correct for sagittal and coronal deformities. In our paper, we showed that you can correct 5 to 7 degree sagittal deformity in the pre-op CT to post-op CT. That is a routine for us, and we are a private institution and not academic, so we have always pre-operative CT and post-operative CT, though, and we can measure that. And then the question of the fusion is as well that, like all muscle-sparing technique, the fusion rate is in higher 90th percentile. And we have published 11 papers, 2 about the preoperative and 1-year outcome with 303 patients. Our 1,000-patient study is in progress. I will keep you updated. Now, the end result is that, you achieve that. I'm not using PEEK cage anymore. I'm using titanium cages. But the result is that you can truly reduce the impact of the surgery on the patient and make even multi-level fusion day surgery kind of procedure. And we have been practicing it for the last 10 years, where we could show even in bigger cases, elderly, most of these patients go home next day. It was hard for me, for myself to really believe that this is really working, but I start taking patient testimonials. Now we have over 1,200 patient testimonials just before discharge, a week later, a month later, 6 months later, a year later, that showing that truly this result as well are sustained. So I'm going to stop here and get some question maybe, but this is actually a demonstration, a cartoonish demonstration of how the approach in relationship to nerve root and the cambium triangle is, but I'll stop here and take some questions.
Couple of questions. So thanks for the talk, and I think the X-rays that you showed are actually really compelling. A couple of questions I have for you. So you're taking a 45-degree approach into the cambium triangle, right? And approximately 45 degrees. Do you have any visualization before you get into the cambium triangle, or is it percutaneous?
And that's a very good question. I started actually using endoscopy with that. And like another doctor as well from Germany, Dr. Weigel, he and I, we talked about that. After a few cases, after significant number of the cases, I noticed that really endoscopy doesn't give me any additional value. So what I did is I'm just using the 2C arm and the value of the neuromonitoring, and I don't aim for the cambium triangle directly. I aim for the pedicle of the level below and just run the probe on the periosteum down to the cambium triangle. And we have been collecting our data. And as well, we tried to have we created what we call a handheld microscope that you can put on the tube and visualize everything. But as well, that didn't really give me any clinical value. So I abandoned that. Right now, you can, but you don't have to have a direct visualization.
Yeah. So, I mean, the extraforaminal approach, as you mentioned, which targets on the superior lateral aspect of the inferior pedicle, like you described, I think it's a pretty safe approach. But I think, as a surgeon, I still personally I feel pretty strongly about visualization of the entry point into the disc, because sometimes you have aberrant nerve roots. It can be a low, duplication, a low runoff of the nerve root. Sometimes the nerve root sits right on the disc space. And I think without visualization, you're going to get 1 out of 100 patients, you're going to get that nerve root. And then number 2 for me, would you mind just describing the discectomy a little bit? What tools are you using? I saw some shavers. There was a mix of different companies on that thing here. Exactly. So, for example, there's one Spinology. Where is it? Yeah, the tool from the shaver seems to be Spinology blades. It seems like you have a little bit of a hodgepodge of different.
That's
stuff
exactly
there.
right.
It's a hodgepodge. Okay, so
let me talk about your first question. I'm still very tense when I'm doing these cases. So as surgeon, we are very risk adverse. So meaning that I didn't start doing that 50, 60 degree scoliosis to start with. I was very selective for my cases, and just my, this is 12 years now, and my level of confidence has increased with my clinical results. And I was very, at first I was very, another question I get a lot is that does the indirect decompression works or not? I mean, most of us that do here this kind of surgery, we do believe that indirect, or what I call physiologic anatomic decompression, works. So I'm still very concerned about visualization and so on, but my experience came from visualizing and not visualizing and making no change in my result except adding 1 hour to the surgery. Regarding the second question, you're absolutely right. This is a hodgepodge of instruments that make your work, in a way, I'm a MacGyver.
Can you take me through? Can you take me through from left to right?
Yes. So on the very left, you see a neuromonitoring probe. That neuromonitoring probe is very specific and is made only for this purpose. You put electrode in the legs in all segments and you stimulate at 3 milliamp while you're approaching. While you're in cambium triangle, I stimulate at 4 milliamp, and then once I'm good at 4 milliamp, that sleeve over that neuromonitoring probe goes down. The probe itself is come down. The probe is Teflon coated, only the tip is available, so you're not dispersing energy and you're not shunting with the sleeve. Then the K-wire goes in through that sleeve of the neuromonitoring probe. Then the sleeve comes out. The dilation device goes in. Even in the most degeneratively changed disc, you can get once you get the K-wire in, the dilator open up the cambium triangle as you go. We know that the nerve root is almost attached to the pedicle of the level above. So we are opening it as we go. And if you're interested, if you go to YouTube, just put the word impossible OLLIF, you will see lots of videos that shows you in actual patient how that works. Okay, once the dilator is placed, the handle comes off. That tube, which is 8 millimeter inside, 10 millimeter outside, goes in, get hammered in with that what I call a barrel, which looks like a barrel of a gun next to it. And the hammer obviously used to put that tube into the disc base. Then you have a... So you see next to the dilator, there is a tube, like a T. That T goes over the dilator, and the barrel goes over the dilator, rests on the T, and then it helps me to hammer that T into the disc base. Then you have a safe approach from skin through the capsule to the disc base, and there are some criteria, how far you go and so on. Then the dilator comes out, then you have a 8mm tube approach from outside of the skin to the inside of the disc. The drill is only creating a path for the rest of the tools. And the second one, the thick handle, is what you call a paddle shaver. It goes in, and I'm going to demonstrate it when I'm doing that. The paddles separate, and it goes up to 16mm that you can turn, pivot, and create, decorticate. Take the end plates off, the cartilage of the end plates off. We know a bad disc, when you do that, actually the cartilage comes off. They're much more easier. As worse the disc is, easier you can do the disc prep. Now, having said that, the third, most of the job is done with that long pituitary that goes in a very specific way and removes the material. What you see next to that pituitary is a loop curette that literally is directional. You go in and make a core cut into the cartilage, and then by pivoting it, moving it up and down, goes from side to side, enables you to remove the material. And then next to the yes, you open it up and the loop goes up, and the loop in each direction goes about, I think, 12 or 14mm. So you can create significant, and the next to that is what we call the articulating curette that goes in and it catches the end plates. And most of this is done by feeling. You know when your instrument is on a bone that you have this high frequency vibration through your finger, you can feel it that you are on the bone. And then the next instrument to that, after you have done discectomy, removed everything, is actually you pack your biologic, and I'm going to show it to you as well. We tried lots of biologic. The consistency of the biologic is important for this procedure, and the ceramic like tricalcium phosphate work best, but they are not the best biologic by themselves. But we have gone through a protocol that we learned over 5 years. We put Jamshidi in. First thing I do in the surgery, I put a Jamshidi in, and I take only the first 5 cc of the bone marrow, which has the much higher stem cells, and then I impregnate my biologic that look like a French fries. It has a certain consistency for 3 to 5 minutes. And then we have had very good results with that. It fits exactly in that tube, and we push it in. And then the next step is putting a K-wire in, taking the tube, that T-tube out, and then putting the cage in. The instrument on the total right side is another instrument that once we have we achieve interbody and posterolateral fusion. We know that for posterolateral fusion, we have to put K-wires. That 3 instrument on the right side is a device that is eccentric, goes over the K-wire. It's centered on the facet, and we grind the surface of the facet and we put biologic there, and we have good result that we achieve posterolateral fusion, not instrumentation. For both sides. Well, now obviously the very top proximal screws, they don't get this device. They don't get facetectomy. Yeah, all the inferior facet, the K-wire, at least the way we put it, we go pretty lateral and inferior lateral to the facet. And then the device centers, because it's eccentric, centers on the facet, and with the pivotal kind of, I have videos of that as well online if you're interested. It truly not just decorticate, it truly grinds the surface of the facet, and we don't just put biologic, we tap biologic into the pores that quite significantly gives us advantage of interbody and posterolateral fusion.
So the instrument, sorry, but from the right side, that is the tool that you slam into the facet joint. Is that serrated in front, or is it?
You got it, exactly. So once the K-wire is in place, I already have gotten my bone marrow from the Jamshidi, K-wire is in. The next instrument is that dilator that just goes on and dilates the fascia and the muscle. The second instrument is what you see next to the dilator is that device that there are two, that is actually 2-piece. There is a conical dilator, which is eccentric as you see, and the K-wire goes as such that when you put it in, it centers, it pushes your device forward superomedial, and then the serrated tip of that device grinds the support of the facet, then the cone comes out, biologic goes in, and the tap, this flat piece, pushes the biologic in. Takes about 30 seconds per facet to do that.
I have to admit that I still visualize that. I think for MIS fusions, especially TLIFs that are, a little bit limited, it's not as, like Vic showed us, like a big graft. I think the posterior lateral facet fusion is really, really important. And I use the navigated drill, accentuate the joint. And then honestly, that's one of the advantages of the endoscope because it just takes you 2 seconds to get it down and visualize. I still like to visualize, wash it out, see the bone, drill a little bit more, but again, it takes a lot of time. I think this is a really, really, really neat little solution. It would be fun to kind of get some CT scans and see what it does.
We have 10 years of CT scan. Every patient of us get pre-op CT, 1 month CT, 6 month CT, 1 year CT, and we have 1,550 patients. I generally follow them up 1.5 to 2 years, but we have 10 years of data that we have collected. Having said that, I struggled a lot because I was trained traditionally to do everything traditionally. I struggled a lot the first 5 years, truly not to do or forego the visual inspection. I'm a pilot, and it was easy to learn fly by vision, VFR, visual flight rules. When I went to do instrument flight rules, to rely on instrument and other information beside my vision, I was sweating a lot as well to go from visual flight rule to instrument flight rule, and it's no different. And I talked to lots of people who do laparoscopy. They went through the same process when they went from open cases to laparoscopic. They still visualize, but just when you learn to go over direct vision, everything is in front of you, just the fact that your hands are in here and your eyes are somewhere else, that requires some training and some practical learning curve.
Sorry, we're going to have to keep going. Just finish up. But
No, I'm done. I'm just answering question. I'm done.
No, so I think it's very novel, but it reminded me of a different procedure you may have heard of like years ago. It's called OLLIF. I had to look it up again because I remember it, and it was extraforaminal lateral or extraforaminal lumbar interbody fusion. It's a similar technique. It was a 45-degree angle into the disc space, and the reason why I think it never took off in popularity was lack of visualization. There's a blind pass in that area.
If I may answer that just 2 minutes. About 9 months before Dr. Kambin died, he and I had a conversation. Kambin triangle, Dr. Parviz Kambin, another Persian like us, was described in the end of 70s, beginning of 80s. This is not a new approach. He told me he took a uroscopic urology scope, put it in, and he did his decompression. And this technique didn't really thrive in US. It went to Asia, Korea, China, Japan, and it came back in pieces. And many people, including Wang in Miami and so on, or spinology, they are utilizing many aspects of this, and they have many names. What they have in common, that it is muscle sparing. You are not far lateral, you are transcambine, and there's a huge difference there because in the far lateral, you are still posterior. In a true transcambine, the reason you can endoscopy with transcambine approach, you are in the retroperitoneal space anterior to transverse process. And that makes it, as a matter of fact, a 360. Now, there is another version of this procedure. I use the same instrumentation. I'm not in cambine triangle. That's a rescue technique that I'm anterior to the nerve root. And I perform it since 2015. I'm performing prolateral with this technique. And I published my paper in 2017 regarding this. I have 300 cases meanwhile for that. But this is not a far lateral approach. It has many names, like EndoLIF. Wang in Miami calls it EndoLIF. So I'm not the only person performing that. There are lots of people with some modification performing it nationwide and globally. Thank you.